All right, ladies and gentlemen, thank you for joining us this morning on the one and only Heme Block, the official 4 talks. I appreciate you coming and joining us. We will start with Dr. Carter Davis. He's at Ochsner. He's the interim section chief of hematology and cellular therapy at Ochsner MD Anderson Cancer Center. He treats patients with heme malignancies, performs stem cell transplant, and CAR-T. Today he's going to talk to us about navigating treatment options in frontline and relapsed refractory diffuse large cell lymphoma. Dr. Davis.
Good morning, everybody. Thank you for being here today. I'm excited to talk to you about the diffuse large B-cell lymphoma space. It has changed a lot in the last several years, and we'll talk about frontline relapsed refractory options in DLBCL, and specifically focusing on bispecific antibody therapies, which is one of the newer classes of therapies that we can use in this space. They have transformed a lot of what we're able to do for patients with relapsed or refractory disease, and hopefully, potentially even in the future in first line. And so the objectives of this discussion are to understand therapy selection in first line diffuse large B-cell lymphoma, which we'll cover relatively quickly, identify bispecific therapies in diffuse large B-cell lymphoma, recognize the role of bispecific antibodies in relapsed and refractory DLBCL, and finally to select therapy in relapsed refractory DLBCL that includes the use of a bispecific antibody. So in this discussion, we'll talk about both on-label indications as well as NCCN guideline indications which may not yet have an FDA label or may not have passed the scrutiny of an FDA regulatory approval. First-line therapy in diffuse large B-cell lymphoma in many ways has looked very similar over the last quarter century. And you can see if you look at the NCCN guidelines that R-CHOP remains a preferred regimen across the board regardless of stage, although there are now opportunities to select alternate therapies, most notably the polatuzumab RCHP regimen, which performed very well in a phase 3 clinical trial with superior progression-free survival compared with R-CHOP in patients with an IPI of 2 to 5 in diffuse large B-cell lymphoma. And so although R-CHOP has been the standard of care for 25 years, there have been numerous attempts to replace it. This slide depicts a summary of randomized clinical trials that compared alternate regimens to R-CHOP in diffuse large B-cell lymphoma in the first line. And the red bars indicate the time over which that took place and the failure of those regimens to achieve superiority compared with R-CHOP. So you can see there's a lot of red in this slide, which indicates that there really is not a better regimen until most recently when pola-RCHP demonstrated a superior PFS compared with R-CHOP. The interesting thing about this is that additional analysis of the patients who really derive the most benefit from the addition of polatuzumab vedotin is largely limited to patients with the activated B-cell type DLBCL, that those patients with GCB subtype, which is the more favorable and more common subtype, don't necessarily do better. And although this is not reflected in the indication for selecting pola-RCHP, it does provide a biological rationale where we might select pola-RCHP for specific patients with DLBCL, and R-CHOP is still acceptable and appropriate for many others. So something to consider and something that I personally use in my practice. So this is just a summary of now longer-term follow-up of the phase 3 Polaric study comparing pola-RCHP to R-CHOP, and with many years of follow-up now, we see a sustained PFS advantage in favor of pola-RCHP compared with R-CHOP, and that has not really changed even from the first results that were released. What is interesting to note is that there has yet to show a true overall survival advantage of this regimen, which we believe largely reflects the strong ability to salvage patients that do progress with alternate therapies such as CAR T-cell therapy, novel therapies, and that will include bispecific antibody therapies. So thankfully, even if patients do relapse, we're still able to meet their needs just as well for the patients who got the polatuzumab in the first line. Despite these advances, nearly a third of patients may still experience disease relapse. So while many people like to talk to patients about how curable DLBCL is, the fact of the matter is that it's not for everybody. And so CAR T-cell therapy offers really impressive response rates in the second line. But not all patients are eligible or able to reach a CAR T center. It can be very demanding. We know that actually most patients who are CAR T eligible or who should receive CAR T don't end up getting it. Even among patients who do receive CAR T-cell therapy, only approximately 40% experience long-term remission. So although perhaps as many as 70% may develop a complete response to the CAR T-cell therapy, a significant portion of those patients do relapse, and so we need other therapeutics either to augment our first-line response as well as salvage patients who are in need of therapy beyond the first line. Bispecific antibodies represent a class of agents that promote interaction of immune effector T cells against a tumor cell. This is a generic sort of image of how a bispecific antibody might work with an antibody that has an antigen against both a CD20 target on the tumor cell and CD3 of a T cell. This enables the T cell to be activated against the tumor cell, and that has been demonstrated to be effective at tumor killing. This also can lead to release of inflammatory cytokines and cause cytokine release syndrome, a well now recognized entity, as well as immune effector cell associated neurotoxicity syndrome, or ICANS. Thankfully, with more and more experience with bispecific antibodies, there's increasing comfort in utilizing these drugs, not just with inpatient step-up dosing setting, but also developing therapies that can be administered entirely in the outpatient setting, using tools such as tumor debulking in advance of dosing and other prophylactic medications to help reduce the initial increase in cytokines. So in diffuse large B-cell lymphoma, there are 4 bispecific antibodies that either are in development, are recognized in the NCCN guidelines, or have formal regulatory approval by the FDA. Those in alphabetical order are epcoritamab, glofitamab, mosunetuzumab, and odronextamab. And so I have a summary of their indications, both based on regulatory approval and in the NCCN guidelines here. Although some of these are not formally approved by the FDA, the inclusion in the NCCN guidelines enables many patients to access these therapies and for many insurance companies to approve their use in standard practice. And we'll summarize both the FDA and NCCN indications in the data to follow. So first we'll discuss epcoritamab and its initial study as a monotherapy, and we'll focus on monotherapies first. But epcoritamab in the EPCOR NHL-1 study focused on patients with diffuse large B-cell lymphoma or other aggressive lymphoma subtypes such as PMBL, high-grade B-cell lymphoma, and grade 3B follicular lymphoma, who had 2 or prior lines of therapy, including an anti-CD20 agent, and failure and ineligibility for auto stem cell transplant. CAR T patients were eligible with a primary endpoint of overall response rate. Treatment included epcoritamab with what is now considered their standard step-up dosing, was given in 28-day cycles indefinitely until disease progression or intolerance. The overall response rate that was observed in this study was 63.1% with a CR rate of 40%. Here are the Kaplan-Meier curves from the EPCOR NHL-1 study, which showed a median time to response of 1.4 months, so really quick acting. When patients often have an aggressive disease, we need therapies that do help them get to a response quickly. And so we see that that response does actually come on relatively soon after starting therapy, with 2.7 months to the median for patients who achieve CR of the time to the CR. So really, by the way that these trials are conducted, that pretty much as soon as the imaging assessment's been completed, we're seeing the responses occur. Median duration of response is 17.3 months for responders, so very durable. And for patients achieving complete response, 79% remain in CR at 12 months. So in this patient population, which was more heavily pretreated, very effective duration of complete response if it's achieved by this monotherapy. At 24 months, 64% remained in complete response as well. So this was really encouraging to be able to see this. This is a therapy that's delivered subcutaneously. So once stepped up, it does not require an especially burdensome toll on the patient to remain on therapy. The median PFS in the overall population is only 4.4 months, and that accounts for the non-responders, and the median overall survival is 18.5 months. So we can see, and the Kaplan-Meier curves demonstrate this well, that for patients with complete response, there's really excellent progression-free survival, but for those who do not respond completely, there's still a lot of unmet need. So those 40% of patients who achieve CR can do quite well. As far as safety and adverse events goes, CRS and ICANS are observed, but thankfully very few severe events. I'll call your attention, to the lower right-hand portion of this screen where the CRS and ICANS are summarized. And so almost half had some degree of CRS, but only 4 of the patients, or 2.5%, had grade 3 or higher CRS, and only 1 grade 3 or higher ICANS was observed, although there was a fatal ICANS event in this study. Glofitamab is another FDA-approved bispecific antibody for monotherapy in relapsed refractory diffuse large B-cell lymphoma. In its trial, it was studied also in a similar patient population, DLBCL or other aggressive non-Hodgkin's lymphomas, PMBL, high-grade B-cell lymphoma, and follicular lymphoma grade 3B. Once again, 2 patients with 2 prior lines of therapy, include anti-CD20 therapy, and failure or ineligibility of autotransplant. And once again, CAR T patients are eligible. The primary endpoint of this study was complete response rate. And so, according to the independent review committee in this study, the objective response complete response was seen in 61 patients, or 39% total. And so, in a similar fashion to what we see with epcoritamab, we see that there is a very durable duration of complete response for those patients who achieve it, although the overall 6-month PFS is only 46%, the 12-month PFS is 37%. So in the similar fashion to what we observed with epcoritamab, glofitamab is very effective for patients when it does work as a monotherapy. One of the big differences is glofitamab is given IV instead of subcutaneously, and was conceptualized with a fixed duration in mind, so 12 total cycles rather than an indefinite therapy. And so there's some consideration sometimes given based on patient factors that may reflect the use of one or the other. Safety and adverse events. We do see CRS and ICANS once again, but also with very few severe adverse events. And CRS is mitigated with Glofit with a pre-treatment with obinutuzumab, which was shown preclinically and to help reduce the rate of CRS. So we see grade 1 CRS in about 47% of patients, grade 2 and 12%, 3% grade 3, and then there was 1% grade 4. No grade 5 events related to drug. So I hate to compare across clinical trials. The purpose of this is just to summarize the data and show that both of these have good overall response, 63% for EPCO, 52% for Glofit, similar CR rates in the patient in the studies in which they were done. Median PFS is relatively short, but that includes the non-responders, and the median OS really will depend a lot on whether a patient responds. The good news is these are very feasible therapies, very effective for patients who need them, and can really help people who have been pretreated and have relapsed disease. Where I think things are most exciting is in bispecific antibodies and combination therapy. These are not FDA approved yet. So they do have reflection in the NCCN guidelines, and I think this is really where we will see a lot of utilization now and especially in the future. Epcoritamab has been studied in combination with gemcitabine and oxaliplatin in the EPCOR NHL-2 trial. So this is a summary slide that was from the manuscript in Blood, which demonstrates this combination. This is a phase 1b/2 trial, so there's no comparison arm in this. And patients did get hospitalized during the step-up dosing, as is considered standard. But overall, we see some really impressive response rates. So we can see that actually the overall response rates in all patients was over 80%, with 61% getting a CR. And for patients who only had one prior line of therapy, that overall response rate is 90%, with 74% of patients having a CR. The median duration of CR was almost 2 years in this study. So by combining a bispecific with chemotherapy, we can enhance the response rate and also get a durable response. So for many of those patients treated in the second line who maybe can't get access to CAR T, they can go on to a very feasible regimen which involves minimal inpatient stays and still get a really impressive response. And time will tell if this could be considered a curative therapy or not. Thankfully, The CRS events were primarily low grade, only 1% grade 3, so very manageable toxicity in this study. Glofitamab was similarly combined with chemotherapy in a study that's gained some notoriety in the United States because it did not get a regulatory approval by the FDA known as STARGLO. And this was a randomized phase 3 study compared to R-GemOx. So patients with one or more prior lines of therapy and not eligible for auto stem cell transplant were randomized in a 2-to-1 fashion of glofitamab plus GemOx versus R-GemOx with a primary endpoint of overall survival. And it did meet its primary endpoint, showing superiority to R-GemOx, which of course is not generally considered what we would hope to be doing in the second line of therapy, but it is an important advance. The main reason why it wasn't approved in the United States is that the percentage of patients enrolled from the United States was relatively low. But despite that, this has still made it into NCCN guidelines as a considered therapy, and once again has very manageable toxicity. And so both the overall survival and progression-free survival strongly favor the Glofit GemOx arm with what appears to be very good durability and sort of a plateau in the survival and PFS curves, suggesting that this is a potentially curative therapy. As far as adverse events with the Glofit GemOx, we do see CRS in 44% of patients, but only 2% had grade 3 CRS, so thankfully also very manageable toxicity. And then finally, some newer data, the SUNMO trial, which incorporated mosunetuzumab and polatuzumab vedotin, so using essentially a chemotherapy-free combination, was another early phase study which looked at combination therapy with bispecifics. Mosunetuzumab has FDA approval in follicular lymphoma, but not in DLBCL. But this has also been a really exciting study to show that, one, it's active, and two, it has very manageable toxicity. So patients, this is another phase 3 trial that compared patients receiving mosun and pola to R-GemOx. They were also randomized in about a 2-to-1 fashion. And so what we can see actually is that the progression-free survival strongly favors the mosun pola arm compared with R-GemOx, median PFS of 11.5 months compared with 3.8 months, and that the overall response rate was 70% with mosun pola compared with 40% of R-GemOx. The duration of complete response was not reached with mosun pola and was only 9.5 months with R-GemOx, so a much superior efficacy overall. And here are the Kaplan-Meier curves demonstrating this. So the mosun pola is clearly superior in both PFS and trending towards superiority in overall survival. And so it's an appealing option in the second line. And mosun is actually completely an outpatient step-up dosing, and polatuzumab vedotin has a lot of comfort. So this is something that can be very feasibly given to patients. And the CRS rates were very, very low, which is probably the most impressive part of this trial. Only 26% of patients had CRS at all, 21% were grade 1, and only 1 or 0.7% had grade 3. So very, very low rates of CRS with a regimen that can be given basically entirely outpatient. There were more infections in the mosun pola arm compared with R-GemOx, so it may not be for everybody, but it is very feasible. So once again, comparing across clinical trials, which is always a little dangerous, these are different populations, we can see that all three bispecific combination options for relapsed refractory DLBCL offer high rates of response. So historically, with our chemotherapy, we would see response rates of less than 50%. We see in every single trial, bispecific combinations give greater than 50% response rates, and CR rates even over 50%. The median progression-free survival is about a year in all these trials, and if we consider the patients who achieve CR, it's even longer. And the median overall survival is almost 2 years, and the CRS rates are very manageable, especially the severe CRS. So in summary, bispecific antibodies represent an important therapeutic option in relapsed refractory DLBCL. Monotherapy, even in later lines, can be effective, and combination therapies as early as the second line show very impressive response rates and CR rates, which may salvage patients who are ineligible for or cannot get to CAR T-cell therapy. And patients who attain CR may achieve durable remissions, perhaps a cure. So ongoing investigations into these combination therapies, perhaps even as early as first line or as bridging to CAR T or alongside other novel therapeutics, may allow us to continue to improve our outcomes with DLBCL and hopefully lead to more benefit for our patients. Thank you.